The four-step approach to oophorectomy post-hysterectomy. We have no relevant disclosures. The objectives of this video are to 1. Review common surgical encounters after hysterectomy, and 2. Demonstrate a simplified four-step approach to resecting an ovary post-hysterectomy. The hysterectomy is the sixth most common surgery performed in Canada. Approximately 9% of people post-hysterectomy will require repeat surgery later in life to remove the ovaries, which may present a surgical challenge. Oophorectomy post-hysterectomy is often a more complex procedure than when the uterus is in situ, even when done for ovarian cysts that are not associated with adhesion formation. Post-hysterectomy, the ovaries are often found in the retroperitoneum and behind bowel adhesions. As such, a systematic approach is required for safety of critical structures and to ensure no ovarian remnant is left behind. Preoperative planning requires a review of the patient's past medical history, past surgical history, and if available, the previous operative note. Imaging may help identify ovarian location and mobility. Our case was a 41-year-old G1P1 seeking a nephrectomy for a left ovarian cyst. Her past surgical history was notable for a laparoscopic hysterectomy for adenomyosis and a right oophorectomy for a hemorrhagic cyst. Her previous operative note reported dense pelvic adhesions. An MRI demonstrated ovarian lesions and an ovary high in the left lower quadrant. We will now demonstrate the four-step approach to oophorectomy post-hysterectomy. The steps are 1. Perform a general survey and take down adhesions. 2. Enter the retroperitoneum and perform ureteral lysis. 3. Skeletonize the infundibulopelvic pelvic ligament, seal, and transect. And 4. Excise the ovary off of the pelvic sidewall. We will now demonstrate these steps in turn. Step 1. Perform a general survey and take down adhesions. Upon entering the pelvis, we pan from the right to the left lower quadrant and notice filmy adhesions between the bowel and the left pelvic sidewall. In order to access the pelvic sidewall and the ovary, these adhesions were taken down with a combination of sharp and blunt dissection. We continued to lyse the adhesions, medializing the bowel until the ovary was seen through the left pelvic sidewall. Having identified the ovary, we then freed the bowel inferiorly using a combination of sharp and blunt dissection. This revealed the pelvic sidewall. We now begin step 2, enter the retroperitoneum and perform ureteral lysis. The ureter was identified through the parietal peritoneum just below the pelvic brim, where it enters the pelvis by crossing anterior to the bifurcation of the common iliac vessels and courses caudally along the medial leaf of the broad ligament. We then enter the retroperitoneum superior to the ureter using a blunt technique. In cases where the pelvic sidewall is inaccessible, a lateral approach can be used. We then identify the ureter on the medial leaf of the retroperitoneum. With the ureter identified, we begin step 3, skeletonize the infundibulopelvic pelvic ligament, seal, and transect. We then began to skeletonize the infundibulopelvic pelvic ligament with a combination of sharp and blunt dissection. We began superiorly and then worked our way down its medial and lateral aspects. Throughout this dissection, we ensured that we were well away from the ureter. With the infundibulopelvic pelvic ligament free from its attachments and critical structures, it was sealed with electrosurgery and transected. We now begin step 4 and excise the ovary off of the pelvic sidewall. With the ovary free of its blood supply, we began to excise it off of the pelvic sidewall with a combination of sharp and blunt dissection and electrosurgery. We will now demonstrate the four-step approach in a second case. Our second case was a 61-year-old G0 BRCA2 carrier. Her past medical history was notable for breast cancer. Her past surgical history included a total abdominal hysterectomy for heavy menstrual bleeding. She was seeking a risk-reducing bilateral oophorectomy. In this case, it is critical to ensure that no ovarian remnant is left behind. We begin with step 1 and perform a general survey and lysis of adhesions. In this case, we were unable to see the ovary in the retroperitoneum or the pelvic sidewall. As such, we begin step 2 and enter the retroperitoneum using a lateral approach. With a combination of sharp and blunt dissection, we dissected in the retroperitoneum. To find the ureter, we traced its course cephalad in the pelvis, starting at the bifurcation of the common iliac. To begin step 3, we must identify the infundibulopelvic pelvic ligament using anatomic landmarks. In this case, it was found superior to the ureter on the medial leaf of the retroperitoneum. To ensure no ovarian remnant was left behind, the infundibulopelvic pelvic ligament was sealed with electrosurgery and transected 2 to 3 centimeters from the ovary per risk-reducing protocol. In cases with significant adhesions, the ovary may be difficult to identify. It can be found by tracing the infundibulopelvic pelvic ligament. We then begin step 4 and excise the ovary off the pelvic sidewall. In this case, we notice dense adhesions anteriorly and posteriorly. In cases such as this, certain techniques can be used to delineate critical structures. Techniques include developing the paravesical or pararectal space, using a vaginal or bowel probe, or retrofilling the bladder. Here we demonstrate cystosuflation to ensure that the bladder is far away from the ovary's anterior attachments. Knowing that the bladder was far from the surgical field, we then began to release the anterior adhesions and the ovary's medial and caudal attachments. We are now left with the ovary's inferior attachments close to the bowel. These were taken down with a combination of sharp and blunt dissection. Although we were confident that the bowel was far from the surgical field, in cases of uncertainty, a bowel probe can be used. With the bowel now far from the surgical field, we began to use electrosurgery. In summary, the 4-step approach to oophorectomy post-hysterectomy allows for systematic dissection, helping ensure no ovarian remnant is left behind and safety of critical structures. This approach can be applied in simple and complex cases.